Welcome to the NRMN Health Research Talk. I'm Ann Smith. Today I'll be talking with Dr. Sarah Knight. Dr. Knight is a professor of medicine with UAB Division of Preventive Medicine, and she'll be talking to us about survey research and psychometrics. Welcome, Dr. Knight.
Thank you, Ann. It's good to be here.
So what will we learn in this talk?
We're going to learn a number of things, actually. We're going to talk about methods to develop surveys and measures. We're going to talk about approaches to conducting a survey and strategies to build evidence on psychometric qualities. I think all of us have participated in surveys.
Yes.
And sometimes we get that call at 8:45 in the evening and they want to do a survey and we think, oh dear. But we're going to talk about how to make surveys interesting and engaging for survey respondents, because surveys are so important.
Yes, they are, especially to research.
So in the first part, we're going to talk about developing surveys, and we're going to go through a number of steps to pretest items and scales and surveys. You'll notice the graphic on the slide, and that graphic is an example of where we start when we start to build a survey. We start with some constructs, and you'll see that this design really depicts the construct of partnership and comprehensiveness in pain management, and shows a number of items. And for example, partnership with a healthcare team might involve the patient thinking that their healthcare team is engaging them in their care, asking what they think is important. So we start with constructs and end up with items and a survey. The general approach is to first really identify a construct of interest. And so I mentioned the idea of partnership. Partnership is a construct, partnership in pain management. Then we start to develop items and subscales, and we may also select established measures, such as we might include a measure of depression if we're interested in understanding pain and pain management. And then we go through a process of iterative testing and revising items and the overall scale. So I said begin with a concept, and this is an example of one. The construct here is self-efficacy. So we think of self-efficacy as a person's confidence that they can do something like manage their diabetes. Now that construct can be broken down into a number of sub-constructs. So you can see 4 here. So for example, how we think about our performance in the past. If we performed well in the past in managing a health condition, that might increase our self-efficacy.
Yes.
And so that's part of the construct of self-efficacy, the subdomain of performance, accomplishments. Now, also there's another circle out there on the right, behavior. And we also want to model or include in our model outcomes. And so if a person has good self-efficacy about diabetes self-management, they're likely then to have good diabetes self-management behavior. So this conceptual framework organizes the whole survey. But conceptual models can also be complicated, and this is one that I use to develop a measure of patient preferences for prostate cancer treatment. And in this model, we have a number of different dimensions, such as a person's concern about their survival, their concern about how the treatment might impact their relationships, side effects from treatment, and so on. So there are a number of different subdomains of patient preferences. And then patient preferences have outcomes, such as the actual treatment choice. And also physician recommendations influence not only patient preferences, but they also influence treatment choices. So you can show complicated mediating and moderating relationships in the conceptual model. And all of this can be important to think about as we develop and evaluate the survey. So again, getting back to our construct, and this construct we're going to show periodically to indicate changes in the focus of our discussion. But here it illustrates that we often use several constructs and come up with items, specific items, that are going to represent that construct in the measure. And so the constructs provide the basis for the survey content. Now, the content domains can be based on literature about pain management, for example. You can talk to content experts, so I might go to my colleague who's an expert in pain. I might also study pain patients and do qualitative interviews with them or focus groups to understand more about what they think is important. For example, about partnering with their healthcare team to manage their pain. And the items represent the breadth and depth of that content domain. So what we start with after we have built a conceptual model is the item. And we start to write the items for the survey, and we use simple and familiar words, and especially words that will be understood by the population of interest. So if I'm developing a survey on pain management, and I'm going to use that survey in people with low health literacy, that is, they don't understand all the jargon we use in healthcare. And so we want to use words that are familiar to them without a lot of jargon, words that are simple. We also want to use as few words as possible to ask each question, and we want to aim for specific and concrete descriptions for each item. That'll help our respondent understand what we intend them to understand. We also are going to be building sentences. So these sentences generally are going to be questions. We're going to be asking a series of questions in the survey. And we, again, just like with using simple words, we're going to start with complete sentences, but sentences with simple structures. We don't want a lot of added phrases and qualifiers. We want the sentence to be relatively simple. We want to ask one question at a time, and we want to avoid what are called double-barreled questions. It's easy to do, and when you're trying to write a survey, we want to get as much into it as possible. And sometimes what we do is we end up with two questions in one, and we don't want to do that because that's confusing, and the respondent won't know what question to answer. And when we write questions, we want to think about our population of interest. As I said, sometimes I'm interested in building measures for people who have less education, maybe a high school education or less. So I want people of all education levels to be able to understand the items and the survey. So I'm going to think about how I can make the survey clear and understandable to people of all levels of education. And I want to organize the questions to make responding easy. I might even start with some easy questions that don't require a lot of thought to answer, things that they know about, like their age or their number of years of education. Those are things that people can often remember easily before we get into measuring other things about them.
So that leads them into it.
Yes, exactly. It leads them right into the more challenging questions where they'll have to really think. It might be about their attitudes towards something. It also might be their experience with pain management, for example. Or it might be to talk about their values, such as the measure that I mentioned that looks at patient preferences for prostate cancer. We ask them about what's important to them. So the other thing that we need to do after we have written our items, we need to select some response scales. And I've noted here a number of different response scales. So you can have dichotomous response scales, like yes-no response scales that indicates the presence of something or true-false. We could also have categories of things they need to respond to, such as do you like to get your health information by TV and a magazine, online, categories. We might also have categories that are ordered, or we also might have what's called an interval scale, and that determines the degree or amount of something. So at the bottom of this slide, you'll see a scale that I've used in my prostate cancer measure, and I ask a question such as, how important is it to go back to work the day after your treatment? extremely important, very important, moderately important, and so forth. That could be used as an interval scale. It tells you the amount of importance of that particular question. These are just a number of examples of response scales. A 5-point Likert scale is a very common one, and sometimes people like to add points. They want a 10-point scale or a 20-point scale. Usually you don't need that many categories in a scale. 5 to 7 points usually are best. When you add more categories, it gets more difficult for a person to respond to it. So you can also use a neutral point, and there's an example of a bipolar scale with a neutral point. And that helps give people an option to indicate that they don't agree or disagree with something. But you can also use a scale with no neutral point to force a person to take a position. Now, a visual analog scale is an interesting one, and that's a line, and a person just makes a check mark on that line to indicate where they stand, from 0, indicating no pain, to 100, indicating the worst pain possible. Those scales actually, while they're simple, they can be very challenging for people to complete. And so often we don't use them unless we really need to have a very fine-tuned understanding of a particular amount of something.
So it's generally better to add some guidance as to what the amounts are.
And use fewer categories of amounts.
Mm-hmm. And for the visual analog, does the researcher who analyzes it, is there a scale that they apply to the line to add numbers, or?
Yes, you could either add numbers, or I've used visual analog scales where I actually take a ruler and measure, and you use that distance between the 0 point and the point where they put the check. Mm-hmm. So response scale decision making is very interesting, and you really want to spend some time with this. And one of the things you think about is its relevance to the construct being measured. So I was interested in looking at preferences, and so I used a response scale that measures what's important to me to help me understand what people value in their decision making. But you could use other scales, like an agree, disagree kind of scale, if you have an opinion, like my healthcare team manages my pain well. Agree very much or disagree very much. You also want to consider how easy it is to use, and use formats that perform well. So again, as I mentioned, the visual analog scale requires a lot of thought among respondents to respond to. And so if you have a survey that you want people to complete in 20 minutes, you don't want to include a lot of visual analog scales, because that will take a lot of time. You also want to use formats that will discriminate well among groups, basically so that if a person differs in that construct, like they really like their pain management and you're looking at their satisfaction with pain management, you want that scale to differentiate that person from the person who does not like their pain management. Sometimes if you include very extreme numbers, you get people bunching up in those extremes, and or in the middle, and you can't discriminate among people who are satisfied and people who are not satisfied. And then finally, you want to use a response scale that will minimize response bias. So for example, including a neutral point will allow people to not select something that they really don't agree with, that they really don't have an opinion about or neutral about. So it's also important in selecting a response scale to think about what your statistical considerations are. So I mentioned that you could just ask people to check categories, or you could even use open-ended questions and have people give you an open-ended response. And that's kind of appealing. You get to get all that rich information. But that is really hard to analyze statistically, and you may not want to use it for that reason. You also want to think about how you're going to administer the survey. Sometimes telephone interviews are easy to do, but if you have a bunch of Likert scales that go from not at all important to somewhat important to very important, and you go over and over that response scale over the phone, you're going to end up with someone who's sleeping on the other end of the phone. So you don't want to use those kinds of scales repeatedly in a telephone interview unless you can mail them this survey in advance, and then they have it in front of them. So you really want to think about the method of administration. And then the population characteristics. People who are very ill have trouble completing very complex response scales. They may be too sick. Cancer patient who's in the hospital after chemotherapy might have a hard time using some of these scales. They may need very simple scales. Someone with low health literacy, we really want to pay attention to those response scales being very easy also for them to complete. And we want the anchors or the category descriptors to be written in a way that someone with low literacy would understand them. So we want to consider all these things in selecting the response scales. After we've written our items and after we've selected our response scales, we're going to go through this process of revising and refining. And this is an iterative process. We may do it several times. We may do as many as 2 or 3 pre-tests before we actually take that survey into the field. And we're going to do the revisions based on expert review. And for people who have study teams, often those experts are right on your study team. So you have your colleagues who are also experts review the items and make suggestions for revision. And in addition to that, a very important part of revising is testing it in the population of interest. And we usually start with a process called cognitive testing, and we use what is called structured cognitive interviews to do that cognitive testing. I usually test on 15 to 20 members of the population of interest. So if I am going to be using my measure among men who have prostate cancer, I am going to select men with prostate cancer to test that survey on them first. We use an administration method that's similar to the one that's planned for the larger survey. Now, I usually start with face-to-face cognitive testing. So I might test a measure face-to-face on maybe 2 or 3 people, and I might look at my findings, make some revisions, and then test again on 2 or 3 people. And at some point, if I'm going to do a telephone survey, then I'm going to move from a face-to-face to doing it by telephone. Mm-hmm. Now, doing the cognitive testing is very interesting because what you're trying to do is understand, do the survey respondents understand the instructions the way you intend them to understand it, the items the way you intend them to understand the items, and the response scales as well. It's also valuable in looking at the feasibility of a survey. So if I'm doing a survey with people who are very ill, and it's a survey with 50 or 60 items, they may have a lot of difficulty completing that.
It's too long.
Much too long. And we also want to look at the respondent burden along those lines as well. So even a short survey, if the items are too complicated, will be burdensome. And we want to look at usability. How easy is it for a person to get through the survey and interpret skip patterns? So sometimes we might say, if you are older than 18, then you can skip items 2, 3, 4, 5. That gets to be rather complicated. And skip patterns can also be very challenging for people to follow. So we want to look at that as well. So those are some of the kinds of things we do. We want to ensure that the survey respondents understand the instructions, items, and response scales as intended. And so we're going to use some approaches that get them to tell us about that. And a really interesting approach that I use frequently, and other people use it commonly as well, is called the think aloud approach. And that's an approach where you give a person the survey, And you may sit with them while they do this, or they could do this on their own. You audio record it, but as they complete the survey, you ask them to think aloud. So they might say, I'm sitting down, I'm reading the instructions, and they might read the instructions out loud. Gee, I really don't understand what they mean by complete the whole survey and then go on to the rating task. What does that mean? Is there a separate part of the survey? So they talk out loud about what they're reading. And you can analyze the interview transcripts that have recorded the Think Aloud approach, or you can, as they're doing the Think Aloud approach, you can ask them probe questions. I'll give you some examples in a minute. And you can also look at their response latency. So if someone takes a long time to answer a question, that indicates it might be cognitively too complicated. So probe questions exist in a wide range. You can ask them about their comprehension. So you say, what does the term outpatient mean to you? Paraphrasing, you can ask them to repeat the question. You might want to learn about the confidence of their judgment. How sure are you that your health insurance covers mental health treatment or drug and alcohol treatment? You can ask them how they recalled something. How do you remember that you saw your doctor 5 times last year? And you can also use some specific probe. What made you think that cancer is a serious health problem? Or general probes. How did you arrive at that answer? Was that easy or hard to answer? And so forth. So these probe questions are very important, and you can ask them during the Think Aloud approach or after. And I like to do a little of both. Mm-hmm. After we have refined the survey based on cognitive testing, we also want to pretest the survey again. So we've finalized the survey, and we want to take another look. And actually, sometimes this can be done at the beginning of a survey. So you ask the first 10 people to take the survey. You don't tell them that you're going to hold their responses aside, but you look at how they responded, and you may make some other final adjustments to the survey based on their responses, and then you go on and finish your survey. You can't use the first 10 then in the analyses of the rest, but you do conduct another analysis that informs the revision. Mm-hmm. So they have provided useful information. It's just not going to be used in the main survey. And the revisions of the survey can determine whether the survey method can be completed as intended. You might decide that you're not able to do the telephone survey, you need to do it in another way. You hope that the revisions are not that big, but this part of pretesting could tell you that. And you also want to look at things like, are they able to complete all of the items? Do they skip items? Are there floor or ceiling effects? Everyone responds giving the top answer, for example. And you look at the overall survey completion time. And then you finalize the survey at last after all of that. So you make the last revisions to the survey, and hopefully you have also revised early on. And I didn't speak about this because I talked more about items and response scales, but you also want to look at the page layout. You want to have an interesting visual display for the survey. Or if it's a phone survey, you want to make sure it's interesting and engaging to respondents. You also sometimes want to include educational material. So if I'm doing a survey looking at colorectal cancer screening, I might want to provide some information on what colorectal cancer is. Mm-hmm. Many people might not know about that. And we might even have pictographs to help a person understand complex numerical information or risk information. We also want to make sure the visual presentation of the instructions and questions is all very clear. Remember I mentioned earlier the order of the items. We want to look at the order of instructions as well. Mm-hmm.
So that's great. So now you've put the survey together. It's simple questions that the respondents will understand and be able to answer. And now you need to give the survey to the respondents. What are different methods to do that?
Oh, great, Anne. I'm glad that we're talking about this because now we're going out into the field. So there are lots of ways to administer a survey. You can do self-administration, just give it to the respondents and let them answer the questions. And that's a great way to do it. The delivery can be in person. So for example, you're in a waiting room and you see patients and you might want to survey them about their satisfaction with the hospital. And so you catch them, and that is actually a really great way to get a good response rate. They're right there, and you can invite them to participate in the survey right at that point. This is an easy, low-cost way to deliver a survey, but there's a problem with it, and one is that if you leave them with the survey, you're not going to catch their questions that they have about the instructions or the items. You're not going to be available to catch errors and so forth. So there's some disadvantages to this approach as well. You can also mail the survey out, and the strengths of this method is it's easy, it costs very little. The response rate is lower than that intercept method that I mentioned, but generally you can get a reasonable response rate with this if you use incentives. But there are biases in this. You get often high non-response to items, and sometimes someone else could complete the survey and you wouldn't know that. Mm-hmm. So you can't be sure that that person that you think is completing the survey has completed it. Telephone administration gives you greater control than self-administration. It gives you the ability to check for responses, but it takes a lot of interview time. And sometimes people don't want to tell you what they feel you think might be something they believe that's not good, or something they did that you might think is bad. So social desirability bias can be a problem as well. And that's the same with interviewing individuals directly. An in-person interview has great strengths in terms of being able to control the responding, but takes a lot of time, and there's social desirability bias. And there are technology-assisted methods that we can use, such as surveys online, using the internet, using tablet computers, smartphones, devices. There are a lot of strengths of these methods. They're easy to give to people. People who are tech savvy find them very easy to use. They're very high value too. They not only allow people to take the survey, but they do the data entry, so there's direct data entry, and that saves a lot of money in doing a survey. We can also assess not just the population of interest, we can also assess environments of interest using ecological momentary assessment. So that's another neat way to get information in certain situations. In addition, one of the things though we have to consider with technology-assisted methods is that there's some sampling bias built into this, and that people who are unfamiliar with or do not like using technology are less likely to be included in those samples. And so sometimes these surveys will miss those people, and that can be a problem for your survey. And they're easy for many people to use. Doing surveys on a smartphone, for example. Many people have smartphones and they can easily use them. So there are fewer people that don't know how to use smartphones.
Yes, I recently saw cell phones being used to text responses to polling. And so the speaker would ask a question and everyone in the room could enter their response, and the data was collected immediately, and the speaker could present it on the screen, the summary of the responses. And that was incredible to have that immediacy of the respondents.
And that's a great way to capture the experience of a person. And that's one of the things that ecological momentary assessment does. People have their device with them, and they may be you can communicate through the device and ask them to give their responses at different times. So it doesn't have to be in a classroom, it could be outside a classroom. In fact, I used a similar method years ago. We used tape recorders at the time to assess pre-sleep thoughts. So the thoughts that someone who has insomnia has before they go to sleep. And we had the recorder set up to beep when we wanted to record a thought, and they had different options. They could say they did not want to record a thought, but they also could record a thought. And so we can do surveys even in the moment in people's lives, the moments that are important to them, or important to a problem that they might have, or important to an opinion they might want to give, such as the lecture you were talking about.
Yes, so you're able to get really rich data through all of these different methods.
Yes.
So, and now we'll move on to the psychometrics.
Great. And psychometrics are strategies really to build evidence on psychometric qualities of a measure. So what are psychometrics? Psychometrics are qualities such as reliability, which is the precision of a measure, and validity, which is the accuracy of a measure, that tells you that you can have confidence in the results. Now you see the diagram of this conceptual model again, and the reason why that's important is that a lot of the methods used to establish reliability and validity will always come back to this kind of conceptual model. We're going to talk about psychometrics, but I do want to distinguish psychometrics from surveys. So psychometrics are used sometimes with surveys, but they're more often used with measures that are often embedded in the survey. So like I mentioned with pain management, you might want to know how depressed a person is. So then you use a psychometrically tested measure of depression in that survey. And the reason why we don't often test the psychometrics of an entire survey, unless that survey is a very expensive survey that's going to be given to a very large population over many years, for most surveys, we're interested in timely assessment. We might want to look at opinions, like opinions on healthcare legislation, or attitudes. We want to look at attitudes on getting secondary findings from whole genome sequencing. That's a very hot topic now. We want to learn about it now. So we want to assess timely topics, and we don't have years to develop the psychometric qualities of measures. So time is needed for that. You usually need a very large sample. So it's not always possible to establish psychometrics for an entire survey. Nonetheless, psychometrically strong measures are important in surveys, and they're used to provide accuracy and precision in the survey.
And how would you describe what psychometrics are?
Psychometrics really refer to a number of different qualities, but mainly the reliability and validity of the measure. And we're going to talk about them in depth and the methods used to establish them. So these are the main measurement qualities that we're interested in: the reliability that represents the ability of a measure to assess the same construct in a consistent and stable way across repeated times. And validity refers to the ability of a measure to capture the construct that is intended to be measured. We've mentioned a number of constructs like self-efficacy. So validity refers to the self-efficacy measure actually measuring self-efficacy, so we can have confidence in that. So both reliability and validity are important, but some people say that reliability is even more important than validity. Now, I'm going to talk a lot about validity in the next section and less about reliability, because there are just a couple main ways to establish reliability and lots of different ways to establish validity. So why is reliability so foundational? So a test can be reliable without being valid, but a test cannot be valid without being reliable. So why is that? You might want to know that.
Yes, I do.
So the reason for that is if a test isn't reliable and it's not stable over time, you can't depend on the measurement. So that means that test has error. It's subject to error of measurement. And so if we're trying to measure self-efficacy, it is never going to be able to be valid. You can never be sure that it's going to measure accurately what we think it's measuring because there's so much error in that measurement. So that's why reliability is so important. So there are two main types of reliability that I'll talk about. One is called internal consistency reliability, and that's the ability of each item within a scale or within a subscale. For example, we talked about those potential subscales for self-efficacy, one being performance, past performance. So each item in that past performance subscale should be related to the other items. Cronbach's alpha is the most common method used to establish internal consistency reliability, and that just refers to the average correlation of over all of the items weighted by how much the items are varying. And when you get numbers in particular of Cronbach's alpha that are below 0.70, that suggests that the contribution of each item within the scale is not strong enough, and you really need to re-evaluate those items in the scale. Mm-hmm. A couple other methods. You can also just split the measure in two different forms or split it in half and have two groups complete the measure and compare how the one half is related to the other half. You can also do what's called parallel forms. So you develop two forms of a measure and then you compare the two forms. So again, using that relationship of 0.70 as the one you don't want to go below. Mm-hmm. And ways of improving, you can increase the number of items within a scale to increase the alpha level, and you can also take items that have a low correlation with the overall scale and remove them, and actually alpha will improve. So those are items that we say they don't hang together well with mm-hmm. those other items. We'll remove it and it will be more internally consistent. Now, reliability over time is one of the most important types of reliability, and that is called test-retest reliability, the stability in responses across time. And so there we take the same measure and administer it twice to the same sample on two different occasions. And we might use a 1 week or 2 week test-retest reliability interval. We might go up to 1 month. Sometimes if you have too tight or too narrow a window, they'll remember exactly what they had answered before and answer in the same way the second time, and that's a source of error in test-retest reliability. But if you have a very long interval, things happen in between. And you really want to capture an interval where the construct that you're trying to measure would be expected to be stable. So as I mentioned, I measure patient preferences. Preferences for treatment change with experience mm-hmm. with having prostate cancer diagnosed. A person might adapt to that diagnosis. And their preferences about treatment might change because of that adaptation. Lots of reasons why preferences change. And so if you use a test-retest reliability interval where preferences are rapidly changing, then the construct is changing. It'll look like it has low test-retest reliability, but it really doesn't. It's that construct mm-hmm. that's changing. So you want to select a time period where that construct is expected to be stable. So you usually use methods like intra-class correlation coefficients for continuous measures or kappas for discrete measures. And here, values below 0.60 indicate very low stability over time and the potential for difficulty in detecting true differences in that measure. Mm-hmm. So that's measurement error. Mm-hmm. And so then you can't be sure about what you're measuring. So now I'm going to get into all the different ways to improve test-retest reliability. And there are a few important ways. One is you want to standardize your administration methods at the 2 time points. You may inadvertently introduce positive and negative cues that influence a respondent's responding at these different time points. So you really want to keep your administration method the same for the 2 time points. And again, as I said before, you want to select a time interval where you expect the construct to be stable. You also may want to do something by giving practice items or education about how to respond to all types of response formats that they will use. That way they're educated about how to respond each time. And so basically you're adding to the standardization. You're giving them a little bit of education about how you want them to respond, and that will help them respond in the same way each time. So those are a number of ways to improve test-retest reliability. Now, there are different kinds of validity that are important. One is face validity. Some people don't think this is important, but actually I'll tell you a few ways that it is. So that's the ability of a measure to capture the construct of interest from the perspective of the respondents. So in other words, the respondents know what you're going to measure. Now, there's some measures that aren't face valid, and intentionally so. It may be a personality measure. You can't tell what exactly it's going to measure. You're just answering questions about what you like, what you don't like, or your attitudes. And from that, there are going to be scores indicating your aspects of your personality. And you don't know that that measure of what you're interested in really is going to relate to kind of your enthusiasm, your enthusiastic person. So, but you couldn't tell when you were answering about what you were interested in that that was going to end up with you becoming an enthusiastic person or being called an enthusiastic person in that personality measure. But face validity is important in healthcare research because it assesses respondents' understanding of the content of the measure, and when they understand the content of the measure, it also engages them more in responding. So prostate cancer preference measures, when I give my measure to men with prostate cancer, they think that measure is important. It gets them to think about things that they believe are important in making decisions, about something that's important in their lives. So rather than having items that are not understandable to them, I make all of those items very understandable to them. And then it's also useful in interpreting the results to those outside the scientific measurement team. So in my measure of prostate cancer preferences, I want all of my other stakeholders or people who are involved in prostate cancer decision making to understand that measure too. I don't want to have a psychologist have to interpret that measure to urologists, to radiation oncologists, and others that might want to use that measure. So it's a really important quality, especially in some of the survey research that we do, and especially among diverse populations. Lets them know what you're really measuring. Improving face validity, having that strong conceptual framework is really important. And you refine that framework by using members of the target population then. So if there are constructs that members of that target population don't understand, or you use words to describe that construct that they can't understand, that may not help you write understandable items. So they can give you feedback on that conceptual model that really allows you to improve the face validity. You can also use the structured cognitive interviews as well. You ask the respondent, explain what this question is asking. They need to explain it the way you hope they'd explain it. If they don't, it means they don't understand it. And it's not for them to improve their understanding. You need to improve that item.
The explanation of it.
Exactly.
The description of it.
Exactly. Content validity is somewhat like face validity, but it really refers not just to the understandability of the item, but also to the coverage of the content. So if we have something like measurement of partnership between healthcare teams and patients in pain. And we're trying to represent that construct of partnering on pain management. We should be sure that it represents all of the different content or aspects of that partnership. All things that are important should go in there. And you establish it by having experts rate the content. So you might have doctors rate or healthcare team members rate that content. You also can look at the content validity index, or there's a ratio that indicates the extent of expert agreement that this represents accurately the domain.
And where would you find that?
Well, you can find it in some of the references that I list at the end of the slides. In particular, the Dillman reference and the Nunnally reference are very useful in terms of giving all of the formula that you want to use to do these assessments. So it's critical to select experts that are going to inform the breadth rather than people who are trying to narrow down the content. You can narrow down the content in other ways, as I mentioned, by using the internal consistency reliability. That might allow you to eliminate items that you don't really need. But you really want the experts to inform the breadth, not to narrow down for this particular type of validity. And you want to begin also, when you're building the measure, with a thorough literature review. That often will give you an idea of the breadth of the content domain and subdomains. And you also want to ask key informants, such as patients or experts. They have experience with that domain, and they can comment on the item coverage of that domain. Criterion validity is another type of validity, and that's the association between the construct and an external criterion. So for example, there are lots of self-efficacy measures. And if I want to develop a new self-efficacy measure, well, maybe if there are a lot of self-efficacy measures, you don't really need another one. But if I'm going to develop a new one, maybe it's going to be used in a different context. I can use some of those other measures to serve as the criterion. Sometimes you also have a gold standard for a measure. When I was building my patient preference measure, there were some what are called gold standard measures of preferences. And I validated my preference measure compared to those gold standard measures. You can assess criterion validity at the same time. You can include both measures at the same time and give them to a respondent. They respond to both measures, and then you look at the correlation. You'd use a Pearson R or a chi-square for categorical scales. You can also look at the predictive validity by looking at the ability of the construct to predict behavior over time, kind of like the criterion-related validity, but you're going to use a predictor that is something in your conceptual model that you think it should predict. So for example, with patient preferences for prostate cancer, it should predict their treatment choice. For self-efficacy, we said it should predict behavior. So in predictive validity, you don't assess that concurrently. You assess the construct first, and then the behavior it's supposed to predict, or the other construct it's supposed to predict later at a second time. So you improve criterion validity with the conceptual framework. As I said, we always go back to the conceptual framework. And often the conceptual framework, you can build in the criterion variables, and particularly you can think about in your conceptual model overlap with criterion. So you could have a self-efficacy for diabetes self-management, and you could have self-efficacy for cardiac rehabilitation, and there may be some overlap between those two constructs, but not complete overlap. If there's a lot of overlap, then you could say cardiac rehabilitation self-efficacy is a pretty good measure to use to validate the diabetes self-management validity. So construct validity is the final kind of validity I'm going to talk about. And that's the ability of the measure to capture the underlying construct and to distinguish various levels of the presence of that construct in your population. And there are a number of different experimental and statistical methods. Some of these are quite complicated, so I'm not going to go into this in great depth. But they include things like latent variable analysis, known groups technique, and I'll show you an example of that, different factor analyses. And you have different statistical methods, such as exploratory factor analysis and various statistical methods to detect differences between groups. This is just one example that I've used in my research. It's called the known groups technique. And so if you have a measure, you expect it's going to differentiate between different groups. In my situation, I wanted to have patient preference measures that would really differentiate between what treatments people wanted. So what treatment would they choose? And ideally, I'd like to make sure that the measure differentiates between not only what people choose, but what they're happy with. And here in this particular test, we looked at people who got treatment and people who chose a type of management strategy called active surveillance. It means they're not going to get an active treatment, not right away, because they have very, very low risk prostate cancer. So they don't necessarily need a treatment according to the evidence. And we're going to look at differences between the two groups as a way of validating the measure. And you can see that the gold bar represents the active surveillance and the blue bar represents those who got active treatment. So I think, as you might expect, those that chose active surveillance were less driven by survival. So other things might be more important to them, like their quality of life or their responsibilities. You also see that responsibilities, such as responsibility for taking care of a loved one. Yeah. And there was a difference there. So that's the known groups technique, and that helped me understand that some of my subscales in my measure were distinguishing between these treatment groups. I mentioned factor analysis, and there are two different types of factor analysis. There's one exploratory factor analysis, and that one does not require a conceptual model. You can use that to identify underlying dimensions in a measure. So let's say you have a long measure, and you think maybe there's some underlying constructs that we're tapping into here. And we don't really have a firm conceptual model for this, but we might want to see if one might underlie this measure. So that will give you these dimensions without this a priori conceptual framework. A confirmatory factor analysis is another approach. It's often thought to be a stronger approach, but that one requires that you have this a priori conceptual model. Now, the problem with exploratory factor analysis is you might give it to one group and you might then give it to another group, and you'll get completely different dimensions. It's often used to explore measures and in the early phases of developing measures. So those are the ways you establish validity, and that's how you know that the measure is measuring what you think it's measuring, that construct that's important to you in your work. You can improve construct validity through the framework. The most important way is really to start with a clearly defined construct and conceptual framework that shows all the hypothesized dimensions. And that way, you can use approaches like the known groups techniques. You can use the strong approach of confirmatory factor analysis to validate the measure. So using the best practices in developing your survey that I showed you, like writing clear items and using the structured cognitive interviews to refine the items, and then thinking hard about what survey approach you're going to use to collect your data, and then using strong measures within your survey. All of those things ensure that you reduce systematic bias and random variation, that really gives you the clarity to interpret your survey results. So if you're going to ask a lot of people to do a survey, you want the survey to tell us something important. You want those survey respondents to have their time go to some good use. And survey research is very important. It can bring a voice to vulnerable populations, for example, that don't otherwise have a voice. And it also can bring diverse perspectives into clear view. For example, we often need that in a democracy. So survey research is critical to healthcare, it's critical to society, and it's critical to democracy and all kinds of important things, because it brings these perspectives forward in strong ways. And so that's why all of these things that we talked about that go into developing a strong survey and validating it and determining its reliability are so important. And so for everyone out there, I hope that they enjoy doing survey research, and I wish everyone the best success with their next survey. It's great, and I hope more people go out and do it, because it will just bring more voices into the forefront. Thank you very much. I'm going to show you a few of the references that I cited in the talk, and I want to point out Dillman being encyclopedic in its discussion of survey research, and Nunley and Bernstein encyclopedic in its discussion of psychometric theory, and Sudman and Bradburn. They have a great book, Thinking About Answers, to help you with cognitive interviewing, and the Willig book is a great how-to tool for structured cognitive interviews. And thank you very much.
And thank you, Dr. Knight. We appreciate this. It's been very informative. Thank you for watching this Health Research Talk. We encourage you to email us with any questions or comments. Also, please take a moment and complete the brief survey on the link on your screen. Let us know what you thought about it and how we can improve it for the future. Lastly, register on the NRMN website to sign up for the online mentoring and be a part of NRMN, the National Research Mentoring Network. Thank you.